All right, go for it. Somebody grab. Start.
So this one, I just touched on this issue of advanced practice providers. And one of the things when we do this talk repetitively is we find that if you put your advanced practice providers solely in triage, which is about the same as waterboarding them, then it leads to high levels of job dissatisfaction, difficulty in retaining them. And so this person notes indirectly that anyway, saying advanced practice providers in the treatment of patients, but not just in FastTrack. So making sure that they have a mix of their day and work life, so that sometimes they're with critical patients, maybe with a greater level of supervision. Sometimes they're in the FastTrack, sometimes they're in triage. You just can't create a life for them that exists of shortening your door-to-provider time by putting them up in triage and because, after 3 shifts, they need to be seen by psychiatry and placed on a hold.
Electroshock therapy. Yeah.
Comments from our advanced practice providers.
Who've been waterboarded in triage.
Who's been waterboarded in triage?
They just started having us work on triage, and 12 hours up there is a very long day.
Oh, very.
Yeah.
So 12 hours in triage is awful.
So even if you divided that in half, where you had half in a FastTrack or in a different setting, it would be much more tolerable, I think.
Yeah, I think the challenge of it is right now we have 2 on shift, and so in the past there was 2 of us in our minor care area with very, very high volumes of duty. So we have a lot of people coming back. There are a lot of the lower extremity belly pains that we're getting for a lot of minor OB patients. So we have 10 rooms back there. So you're back there by yourself with 10 belly pains, and the person, there's another person who up in triage. And so it's just ended up being this mismatch of you're both a little miserable all day long. And so we end up switching how we do today.
So you have
Well,
2
you mentioned
people out
something
there.
else. You mentioned something else, which is how FastTrack morphs depending on what's going on in your department. So you're busy. Suddenly they think belly pains and HIV positive this and that and cancer patients with chemo start arriving in FastTrack, where the triage note says headache or something that should be trivial, but then you're like, wait a minute, they took his eyeball out, he's had chemo, this is not minor. And then if you bark about it and say this is inappropriate for FastTrack, you get some comments about how your spine might be a little rubbery and you're a whiner and high maintenance. And I think those are things that we all have to pay attention to, because if it's going to be FastTrack patients, they really should be FastTrack patients.
Yeah, there's an argument about having what level providers should be out at triage, because triage, first of all, triage just means sorting, right? That's the French term is to sort. And what you're trying to do is figure, and you should never have triage if you have empty beds in the back. They should all go straight to the back.
So
There's an
bedside
empty bed.
reg always
bedside
comes
reg,
up in
it should
this.
always go to the back. But triage is meant to sort the people that are waiting. And often we end up with people waiting. And there's an argument to be made that what type of provider should be out there. Should it be an advanced practice provider, or should it be the most experienced person in your department, whoever that happens to be, who can really say, this one's a sick headache with some confounding factors, or this sore throat is more concerning because the throat looks really good and they're kind of hoarse and I'm worried about the epiglottis in this one. There's someone who can actually sort that out. And I think as a specialty, we're having some trouble figuring out the best way to do this. Unfortunately, I think one of the I just spent an hour on the phone last night with a graduate of mine who's going through this at her place. She's medical director. And her administrator basically said, we are going to get less than 30 minute, and they're aiming at a less than 15 minute door to provider time. And we are going to do this. We're going to advertise this. You will get this done. And the way to get it done is to put an advanced practice provider greeter. Basically, you're a greeter is all you really are. You're basically saying, hi, I'm your provider. Ta-da, check, next. But the motivation is totally wrong. Right? The motivation is not good patient care. The motivation is a checkbox advertising slogan rather than truly good patient care.
So whether it's a physician in triage or an advanced practice provider in triage, one of the recurring themes in these things is, in addition to decreasing the door-to-provider time on someone who's going to come into your ED, the real value of it is if that person can do meet, treat, and streets on real quick ones. So many of these papers over the last couple of years have said it's pointless to put a physician in triage or an advanced practice provider in triage if they don't have a nurse who can help them get things done and do discharges. Right. So I think if you're going to move a provider to the front, they need nursing support. That's a recurrent theme. And whenever they have the opportunity to do so, they should do meet, treat, and street.
One of the things we discovered, we have NPs at our place because they have furnishing licenses. They can actually do their, we chose NPs on purpose for a system issue. But one of the things that we've discovered, and for advanced practice providers out in triage with this nursing issue, is if you want to bring out passive aggressive behavior, put an RN next to an advanced practice provider taking orders from that advanced practice provider. The roadblocks that our nurses have put up for our poor advanced practice providers who are put out there in hell, we've actually had to have an intervention. We basically had to have a big meeting of everyone to say, just get a grip.
Get over
patient care is what's important here.
Untwist
Get
those
over
panties.
this stuff. Yeah, exactly. It was ridiculous.
It raises
Crazy.
the whole topic of waiting room management, which is a common theme in a lot of these questions. So there's the whole point of who do you have in triage, what do they do in triage, and then a couple of the questions here have to do with protocol orders. Do you find it valuable? Do you find it an appropriate thing to have, even if you don't have some kind of provider in triage? Do you want your nurses to be initiating orders based on a protocol-driven guideline? How many people are working that you get the patient back and they've already got their CBC, Chem 99, and
D-dimer,
Whether they
BNP,
need it or not.
and
And the
troponin.
D-dimers and the tropes tend to be
And
what
the
hurts.
BNPs.
And
In our department, the nurse always comes to me, gives me a quick synopsis of the patient, and she'll ask to go to the Institute protocol acceptance. And based upon that information, I said, yes, or let me look at the patient first. But it really helps if they can go ahead and get the ball rolling and really loosen the contact sense before I get to the patient.
so one of the ways we facilitated that question at our place is just a simple technology thing. If they have to find you, if they have to walk around the department and find you for that interaction, especially in a department that's as big as ours, is a pain in the ass for everyone. So we went to voice-over internet phones. So whoever's in triage doesn't even have to leave triage. They have their voice-over internet phone. You have your voice-over internet phone. And so they can reach you immediately without running around the department. Is he in the bathroom? Is he, where is he? So that's helped. That little technology. How many are using voice-over internet phones in your EDs?
Yeah,
So for those of you who aren't, I would just tell you, some PMD calls in for you. You can actually handle this much, much quicker. In our setting, we have this thing called the Medical Alert Center, which is coordinating the transfers. So the MAC can find you. The senior resident can find you. And so when you're
you can
moving
find the
around doing other things, I think this is such a simple technology, and it enhances communication from triage to the back and vice versa in a way. Because often this triage location is remote and behind closed doors from the ED. So if you want to have that kind of communication about, let me take a look at it real quick, and no, I don't think so, or yes, I do, that makes it much, much easier. And the last thing I wanted to say, so we've talked a little bit about triage work and FastTrack work, and I just want to hear from the advanced practice providers in terms of your opinions. I know what they say at our place, but our advanced practice providers really appreciate it when they also get a day in the main ED, where they get to work with some critical patients. They're obviously working in a little bit different in terms of more supervised role in that setting, but they also really look forward to those shifts. So true, false, don't care. What's your guys' feeling about that?
I concur. A lot of times if you're kind of in a fast track, majority of your career, you lose a lot of your skills, you
Yeah.
lose all your knowledge, and it ends up not being beneficial to the role of the
And I think the variability, at least one of the things we see in our advanced practice providers, is they come in with wildly different experiences and levels of experience beforehand. And so that the educational benefit of having some time in the main ED where they're closer, at least in our academic institution, with faculty and a teaching environment and stuff, it just keeps the neuronal pathways of sort of changing what your knowledge base and fund of knowledge and approaches open. So I think those are all things that I would say about optimally using advanced practice providers. And there's probably a lot more that we haven't touched on.
I think if you're doing the protocol orders, like some people said somewhat sardonically, whether they need it or not, you want to make sure you're not digging a hole for yourself. So having some kind of like a D-dimer in triage based on chief complaint would be a very bad idea, in my opinion.
Yeah, we took ours out. So the advanced practice providers out front can't order a D-dimer, BNP, or troponin without asking us first. Yeah.
Yeah, I think troponin is less controversial than it used to be when you had like Amal Mattu saying, well, if you open the door with a troponin, you've got to close the door with a stress test. And so there was this notion that if you even thought ACS, you had to drive it all the way through to some kind of testing like that. And I think we have evolved beyond that at this point. But now with the new high sensitivity troponins, as we talked about yesterday, a troponin is now the new D-dimer, that you can believe a negative most of the time. You can't so much believe the positives.
Because so many other diseases are going to ring that
Right.
bell.
Right. Gotta
Well, it
figure out
doesn't
what
necessarily
is,
even
right.
need, as I mentioned yesterday, that the new high sensitivity troponins, which are 1,000 to 10,000 times more sensitive than the initial generation, will pick up troponins in
Sepsis,
normal
DKA,
people.
pericarditis,
Yeah. But even normal
et cetera,
people.
the list goes on and on.
People with chronic coronary artery disease, they have mild elevations of troponin off the time. So.
This person wants to talk a little bit about creation of OBS units for low-risk patients, and then it's notes in there that in their system they run it by advanced practice providers. How many of the advanced practice providers are running the OBS unit? They run it at our place with physician oversight, so a few of you. So OBS is, are your OBS units working? How many people in there, let's see, how many have OBS units, period? All right, and how many of them are strictly protocol? You can only get into OBS if you meet some well-defined criteria for some disease entity.
We used to, not anymore.
So some people are doing that. So we loosened ours up, and now the joke about our OBS unit is we call that area of the hospital Pilo that isn't.
Pilo that isn't?
Pilo that isn't. It was sent there because the urine was positive, but that's not what they have. What they really have will be discovered at some later date.
Actually, our OBS unit has been a godsend, an absolute godsend. And what we do when we opened a new ER on Easter Sunday. Thank you so much. Whose idea that was, I don't know, but anyway, that's LA County. We opened it Easter Sunday. We also
I
went to
think
our
the
new,
crucifixion idea
Yeah,
is
I don't
perfect
know.
for that.
We also this is a year ago. We also we got our new EHR. I love this in a trauma center. They started our new mega EHR, hospital-wide EHR, on Halloween day in a trauma center. Thank you very much. We found every possible problem in about 12 hours. It was unbelievable. But anyway, our OBS unit, what we decided to do with our OBS unit is now it is staffed by a hospitalist. The care goes directly from us to them. It's a separate unit in our ER. It's on the first floor. We use it for chest pain issues. We use it for true things that need to be OBS'd. And we also use it for that person that needs that 23 hours worth of, let's figure out how to disposition them, get them into some sort of care center, get them into something where you actually can take care of a lot of the problems that would suck up 12 to 24 hours of your time in the ER that are done there. We also hire 24-hour caseworkers. We have 24-hour social work.
Yep,
So
we
all
did
that
that as
stuff
well.
gets done out of the main ER. And it's unloaded us, and this is, we're whacked out, not as much as they are, but we're pretty whacked out where we are. And it's made a huge difference in our patient flow. Enormous difference.
How many of you have
It's been great.
24-hour social workers 7 day a week?
Oh,
Anybody?
that's the best. Fight for that because it takes care of a huge
So
amount
we're
of
a
trouble.
county hospital, as we've said, and it's not the same population as many people see, but I could tell you that has made a really
Oh, my
big difference
word.
in my life. A 24-hour, 7 day a week social worker, because we have so many of our issues and placement problems, and even the investigation, what's going on, like find me the family,
Yeah.
Please send the search beagles out to find the family. Get me someone to talk to. So I don't know at what census it becomes practical to support a 24-hour social worker, but it's certainly been really helpful at our place.
Godsend.
Now, let me ask this. When you admit people to OBS, how many of you are having a financial... Now, obviously, don't admit them. It's not an admission. But when you send someone to OBS, how many of you are having a financial conversation with your patients about what OBS means? Because OBS can sort of screw them, right? Their copays are often much bigger. And I think that the ethics of using OBS has been somewhat kind of sidestepped in a lot of places. So I'm interested. You say you do? Tell us about that.
So we have a very high Kaiser population, pretty high.
Loud.
Love that.
Population, but many of them have an HMO plan that's high deductible.
So you have a large Kaiser HMO high deductible patient population.
And it's the odds that's included in their ER copay versus if they're admitted, if someone has a $5,000 deductible, they're gonna need it.
So OBS
Ouch.
helps them. So OBS keeps their copay, their ER copay, not their in-house copay. So that's helpful for that group.
Now, so you specifically mentioned Kaiser, because in our place, if we were thinking of sending someone to our OBS unit and they were a Kaiser patient, we have, and you probably do too, the EPRP program, the
Right.
Emergency Patient
Repatriation.
Repatriation Program. Like if you're
sounds-
Kaiser, you belong to a different nation.
Country.
And we'll have customs check with you at the border and see if we can bring you home. But our Kaiser people are pretty aggressive about not
They're
letting
really
you go to
aggressive.
OBS with these people and bring them home. Not true?
They come get them.
We are Kaiser.
Oh, you are Kaiser.
You are Kaisers. So it's the non-Kaiser people. So you're talking about the non-Kaiser patients at your facility that are going to OBS? Both.
Yeah, we can keep both there. Our hospital's not.
So you're let me just get this right. So you're a Kaiser facility, and if you send a Kaiser member to OBS, they're going to get creamed with a copay? That's not right. No? Okay. Phew. You scared me.
And if it doesn't matter if they're Kaiser or non-Kaiser, but we see a lot of Kaiser patients. I'm more familiar with their particular plans, like at Blue Cross Boston or something like that. And so they will have, that'll be included in their ER copay, like they're
Yeah.
there. You're not gonna get an additional OBS copay versus if they're in it. And that's just for some particular plans.
How many of you so she it's just about this whole OBS thing and what the financial ding is. So
Depending on the insurance status.
The financial ding is bigger. She noted that they're having these conversations. I think in a fair number of EDs, I think when we decide to send someone to OBS, a lot of times that conversation is skipped.
Yep.
And the patient finds out at the end that they got a massive copay, which is one of sort of the dirty secrets of OBS, which is that the financial burden may be greater for the patient. So I just wanted to sort of see, we've had some pretty active discussions about this where people are like, we don't talk about it, or we do. I've had problems with them wanting to go AMA when I talk about it. Then I go to admit
That's the
them. They
Medicare
fail
patients.
interqual. How many of you are interqual?
interqual. Oh, my
Anyone
God.
interqualing here pre-admission? So that's new for the county. It's a pre-screening with interqual to try and decrease denied days.
It's so crazy.
Go ahead. You had a comment. Shout it out, though.
A couple of things we did. One is we put a video together on an iPad for observation because
Beautiful.
observation changes, and I don't know how it affects your insurance.
Right.
We have different policies and people pay different things, so we give them a video, and they sit there in the room with the iPad, or the family member making decisions if they're, an elderly patient, demented or whatever. And that gives them the front end view of what ops is like. Like you said, they want to go AMA, then they say this is going to cost you X amount of money. And with the interqual thing, what I've done with our hospital is I ask, how many times have we done admissions that get denied and then petition them? Because there's 3 levels of petition.
Yeah.
And my answer at our facility was we've never used the 3rd level. We've used the 2nd level once, and we've only used the 1st level 4 times. It's like,
As far as challenging interqual, right? So interqual, for those of you who don't know, is when you get to the point of deciding you think you need to admit someone, what we do is we hit a little button, and there's basically a utilization review person that comes and looks at. They get this book that they flip to. Your admitting diagnosis is congestive heart failure, and there are certain criteria you have to meet to be able to be paid for that admission. They have to get 2 doses of a diuretic. They have to be oxygen dependent. Blah blah blah. All these things. And if there's something that isn't met, one of those criteria, they'll come to you and say, "Can you give another dose of Lasix? Can you do this?"
So game the system,
So you
or
can
you're
either
going to
game
get a
it.
denied day.
Right. So our residents give basically 40 milligrams of Lasix and then 1 milligram of Lasix. I mean, it's kind of gotten ridiculous. It's kind of crazy. But there's some things in interqual. For instance, unstable angina. You cannot get admitted for unstable angina and get paid unless your troponin is up or your EKG changes.
Or you're on heparin.
And how stupid! I'm not.
Because
gonna
I don't put all of them on heparin, but heparin will get you in
some
for a
bean
therapeutic
counter in a
intervention.
room somewhere didn't get the concept correct. Unstable angina doesn't have a positive troponin, and their EKG often doesn't change, and I'm not going to heparinize that person. So hello. So this is where those challenges work, and actually a couple of them have gone through and worked where you can challenge this stuff. And if you don't have interqual, an equivalent of interqual is coming your way. Coming your way. It's all sort of part of this.
So this
change
is
in our
the
healthcare
new
system.
war zone in terms of billing and coding at the junction of the ED and the hospital. For the ED, the old war zones were down coding. You didn't meet the E&M 4 requirements, so we're down coding you. You'll be paid for an E&M 3. If you didn't meet E&M 5, you'll be paid for an E&M 3. So downcoding was one war zone. We all learned the rules for how to meet the requirements for E&M 1 through 5. The next war zone was once you got good at coding and the third-party payers didn't want to pay you, then they went to bundling. Right. We don't care that you did a digital block and sewed up the finger. We're calling that one thing. We don't care that you did procedural sedation and reduced. We're not paying for one or the other. So bundling was the next war zone, and now the war zone is medical necessity. And the measurements of medical necessity are stuff we don't really love, but interqual is one of them. And you would like to think that your diagnosis, your admitting diagnosis, ought to go right to an interqual admitting diagnosis. You're like, it says acute STEMI. Need I say more?
Right.
No, actually you might.
You do.
So, for example, in interqual, they've never heard of the endocrine system. That's how good
That's true.
That's how good interqual is. So diabetic ketoacidosis, I'm pretty sure that's a slam dunk admit. No, it's not in there.
No, it's not.
That thyroid storm, not in there. Myxedema coma,
It's like whoever had
not
the
in
endocrine
there.
section didn't show up for the
There are no
meeting.
endocrine diagnoses in there. So you can get those through, but you have to get them through on the therapeutic requirements, like an insulin drip or other things. Comment.
Jesus.
So we have a quality assurance service that sort of buffers us so that if they decide they're ops, they have to go talk to that patient. I don't have to go talk to that ops.
But do they do the financials?
So that actually is a really great answer to this because I can't keep track of insurances anymore and which one covers which and who has which copay
So
depending
what he said
how
was
you work
that
the
they
system.
have a quality assurance nurse who every time someone's going to go to OBS, that quality assurance nurse who knows more about the insurance and the payers and some of the other things will talk to that person and inform them prior to their landing in the OBS unit.
Right,
I
and
think
what's
that's
nice
a
about that
reasonable-
is it takes, because our job really is to, I want to move people through. I want to take care of my patients well. I don't want them to get burdened with a bill, but I really need to move them through. So I like the fact the OBS exists. This is an extra kind of nice layer of saying, and we'll make it the best we can for you without dinging you with, depending on what your health coverage is. And there's only so many things I can throw around in my brain. I kind of like, my head is
Yeah, I get
exploding.
that.
I feel like Linda Blair with my spewing green stuff and my head is turning around, trying to remember everything. So that it's nice to have somebody that's their job.
The bad side is you have to pretty much tell the quality assurance source about every admit or ops patient.
So now it becomes an additional step
Additional
that creates
step.
a potential bottleneck
Right.
and increases potentially your access block.
And the good side is they have to go talk to the patient about that financial
Yeah.
responsibility they're going to have. And it's sometimes very big.
And it can be devastating for people. It literally can be the difference between a $100 copay and a $5,000 deductible.
Well,
I mean,
and
that's a
for
big
years,
difference.
of course, we were afraid to talk about any kind of financial implications for the patient, partly due to EMTALA.
EMTALA prevented you from having any of those conversations.
So we
but
had-
theoretically, by the time they're going to OBS,
yeah.
stabilization has
You
occurred.
hope that they stabilize, right. But before, you had to do all necessary procedures, consultations, and so forth for stabilization, really before having financial conversations for fear of financial blackmail and, oh, we won't treat you, and they're walking out the door.
Right.
But from just a humanitarian point of view, letting people know what the downstream costs are now in the high deductible age is really more and more important.
Here's one that I don't think we see that often, but which I think personally is really important. This person points out that one of the things that can optimize your ED operations is having some specific system that deals with urgent same-day appointments, rapid follow-up. And I think, and Dave Schreiger has done a lecture on this that said, for a lot of things, like we talk about the nondescript belly that maybe you didn't CT because the patient didn't look that sick, that person might need a belly check in 24 hours. We know that longer than 24 hours is wrong. We know that there'll be fallouts with acute appies or other things happening. So the real issue is how do you get someone who might not have a good relationship with a PMD, even though they have an HMO, how do you get them next day or 2-day follow-up? We developed a same day, meaning next day, cards follow-up, and we had a limit. You could do 9 a day or 10 a day. They would hold 10 slots open. So that someone who you didn't want to admit to, for an exercise treadmill or something like that, one of those at that sort of junction of low intermediate where something was tweaking you that you were worried more about it, you could get them seen tomorrow. And I found that one of the most effective things at decreasing unnecessary workups was the ability to, and maybe I was fooling myself about what they would be able to do. I'm certainly open to that interpretation. But at least I felt better about being able to see, we're going to have you see someone tomorrow and see how this is doing. So I think that's an understated, and really what that points to is that we have become, in emergency medicine, really the access point to the healthcare system for huge numbers of people, and that one of the things that would help us do less in terms of resource utilization and testing is having actually another portal of access tomorrow besides us. Because for many of you, if you want to belly check tomorrow, you got to send them back to your colleagues, right? You got to have them come back to your ER. Comment loud.
Along that line, I just developed a program at our ER called Familiar Faces. And so
Familiar faces, I love it. Familiar family faces for family-centered care.
with great love, we've developed a multidisciplinary group that meets every month, and we have our residents do a case analysis of each patient that we've nominated for our group. And the nominations cover utilization data, as well as even anecdotal behavioral problems where maybe they're there enough, they have generated big bills, but they're probably so we have patients that we targeted, and we've had very surprisingly good results.
So this is about your frequent flyer people.
Which you're not allowed
Which,
to
by
have-
the
yeah,
way,
I
you
like
can't
that.
use that
Yeah.
term, but familiar faces conveniently is abbreviated
And
FF as well. And so on the column on your EMR, you could put FF. And everyone, we call them at our place NSAs, which is needs special assistance. That's a clue to you that that chart does not belong in FastTrack under any circumstances.
Actually, but that system is actually, we all have our frequent flyers, familiar faces, whatever you want to call them. We all have them.
I like
and
it.
there's some published data that looks at doing exactly what you're doing.
Yeah,
One study.
Maureen McCullough, who many of you heard talk on PEDS things, really spearheaded our equivalent of the
And
Familiar
it's
Faces program
awesome.
and had
Keeps them
some
out of the
tremendous
ER,
successes.
Keeps the costs down. It's remarkable.
Very surprised by the response because there's probably going to be
Loud.
Loud,
This is
loud, loud.
great.
there'll be a scholarly project to come on this, and we think what we're finding is that there are subsets of patients that a simple intervention of a kind conversation and a good care plan, these patients stop coming.
And they don't necessarily even want to be there. They just don't know any better on how to get into the system.
Why didn't we have this discussion 4 years ago with 300 visits?
Sometimes
There's going to be subsets.
It's really helpful. And I think, so the one, they did it through our family medicine program at Harbor, and there was one individual patient who saved the county $250,000 in a single year. It was a sickle cell patient who was in our ER almost daily, and they kept him out of the hospital for an entire year until he got really sick. It was remarkable. So this kind of intervention makes and it validates them as individuals, and they're not just part of the blob of patients. And it's really
we had an NSAer who was a chronic inebriate who was, when he was drunk, particularly irritating. So in addition to being a chronic inebriate, he was a chronic blunt head trauma because he would piss people off when he was drunk. And, I love asking medical students, why are alcoholics at risk for subdurals? And they'll answer all these things that are not the truth because they don't have any real life experience. They'll say, oh, it's factors 2, 7, 9, and 10. And I'll go, you're right. And they'll go, it's atrophy and stretching of the bridging veins, making them at risk for bleed. You're right. And then they'll keep going with all of these things. But none of them will say the real truth, which is they have behavior that makes other people want to hit them in the head. And so this guy had, and I'm not joking, 275 head CTs. It was very clear in like a 2-year period. It was very clear that our plan for him was to irradiate him until he got CNS lymphoma. And so they did an intervention, and he actually, alcohol recidivism is high, but they got him into a program. They worked on some housing for him, and he dropped to something like 6 visits a year. Was really successful.
wow.
So
All right,
I think those
all right,
programs,
David,
if
what do you have
that
down there?
population, are good.
You've got to report that 275 heads.
Oh, yeah, no.
Impressive.
This one I like, and it's an interesting question. First of all, it talks about, it's a waiting room management thing, but part of the question was, I'm having trouble moving patients out of beds back to waiting room. So it gets to the notion that we've
You don't
struggled
own a
with
bed.
as
You don't own
well,
a
that
bed.
you don't own the bed. And I think one of the advantages of an EMR back compared to clipboards is that you theoretically have the capability of moving people around electronically. What a lot of departments have done, or at least some have done, is what's called an internal waiting room. So
Or an internal discharge unit.
you've got the external waiting room where they're queuing to get in, but once you've seen them and evaluate them, and you're just waiting for whatever it be, a blood test, a radiology result, and they're stable, they're comfortable, can you move them to an internal waiting room and then either see them there and discharge them from there, or just call them back to review the results? And that has been a successful intervention for throughput time in a number of EDs. There was a project called Clockwork ED that came out, I don't know, 15 years ago, and that was one of their key recommendations, that you do some kind of patient utilization of moving them out of their own bed. What I find interesting, because we can't do it, our patients are just plugged into their bed, and God help us, we can't move them.
So there can be nursing resistance to this, because they'll be like, we're still responsible for vital signs on those people in the internal waiting room, so you can't keep bringing more back. I got to be at a 4-to-1 ratio or 5-to-1 ratio, and so if you keep bringing people back, we're all over ratio. So that's the blowback we get, although we do this to the degree they'll let us.
I think patients are amenable to this, and sometimes I have them ask, it's like, I'll tell them, well, we're going to get an ultrasound, that'll take about 2 hours, and they'll say, and where do you want me to wait? And it's like, well, you get this bed and you get to sit right here, even though there's a 2-hour wait in the waiting room. I think their own just internal sense of what's appropriate is like, well, surely you don't want me to just sit here using up your bed. And I think the answer should be yes, but actually affecting that change, I think, is very challenging. Are there people who do that I've
Tell us
seen
about it,
you, it's
Mary.
comfortable?
And Mary, you do it, right?
You guys do this. Loud.
We have people not on their bed, and they wait there, and the nurses don't give any blowback particularly. We also don't do triage. We do simple screening, blue for bad and G for gold, and that's good, and that's it. So we got rid of all the triage stuff. So people come back in our door to provider times during less than 20 minutes, and people just shift in and out of their beds, and they wait for diagnostic results and all that kind of stuff, and discharge from what used to be the triage center, and their phones work out there, and the TV's on,
Yeah.
the Packers game is on, and their family members can be with them.
What's your nursing there? So what you do is you said you have no triage. People basically get their quick screen reg kind of thing and get them into the system, which is smart. And I'll tell you, our EHR destroyed that. But
5 seconds in a set of vitals, and an experienced nurse who says you're sick.
right,
And if you get pulled back then, you get an intake from a formal nurse. This is on the good as gold side, not the dying folks.
sure.
And I'll go see them, we'll get their x-ray, they wait in the
And then what do you do nursing wise out in that waiting area? Because you're in California here. You're
Do they
part of
get
the same
ongoing
rules we
vitals?
are.
California here, and they don't get repeat vitals until discharge. Okay, if the nurse is concerned, again,
Do you do a ratio out there? Because in California, we're stuck with this rule of ratios. And in fact, they're making it stronger as kind of,
because of what we designated it as, for whatever reason, CMS does not require the ratio.
what do you call it?
DRD, discharge results and diagnostics.
Discharge
So it's a
results in
separate-
diagnostics?
It's an internal area.
It used to be half the triage area, okay, and now people come in to screen and decide. They come back, they sit in chairs, they may not even sit in a bed or a gurney, and we'll do those folks there. Some people are brought back to beds, and then they will go out there and wait for the diagnostics or the lab. The sick people are out there too.
I'm just interested because we've talked about this at our institution a lot of trying to find a way to do this. And it sounds like those people never make it back into the main ER. Is that correct?
Well, they'll be sitting on chairs in the ER, okay, trying to get that as a non-fire department escape room.
Right.
Conversation, but if you come back with an ankle injury, you're going to come into a screening, you'll sit in your wheelchair, I'll see you, the nurse will be your intake here, you'll take x-ray, you know that's a TRD, and you'll never be in any bed.
But they're still technically physically in the ER. Because again, our nurses have given us no end of grief. And it's basically a flat out no. If it
Now,
doesn't
the
hit
county
nursing
nurses,
ratios,
just to
they
be
won't do
clear,
it.
are not in the California Nursing Association, which is
Right.
one union. They're in the SAIU, which is a little bit like Al Qaeda of the Arabian Peninsula in terms of their negotiating patterns. So it's one of the reasons we have problems.
Our nurses are not unionized yet, okay, good, bad, or indifferent, but they did complain to the nursing board in California
You won.
Really?
So if you want to find out what we didn't say, you have to talk to my nurse consultant, but they,
That's awesome.
Comment here, loud.
What are the privacy concerns with that kind of scheme? You discharge people talking,
So he's talking about privacy concerns, and I'll tell you, do not cross the line of violating someone's privacy. And do you have a special room you pull them into to talk to them?
we have a special room we can take it into.
Yep.
Yeah.
And all that kind of stuff, I'll sometimes say to people, I understand you have an ankle issue, and they ask me your questions in public, or do you want to go to a private place, and they'll say yes or maybe, and they all say yes, as they know it'll be faster. And if you need a pelvic exam, a belly exam, or the intake screen needs a bed for interview, I can move you to a private interview place, it's the intake area, bed, and it's much more fun.
So this all relates also to this idea of having chairs, not beds.
Yeah.
So a bunch of paper has been written about the recliner thing, and sometimes,
love it.
I get upset when technology. So in the way back, so 10 years ago in our main ED, we had something that was really beautiful, super functional, called the Prevental Parlor.
Yeah, it was.
So it was 3 recliners. They had peak flows stacked to the wall. They had a drawer that was filled with Prevental and
could
Atrovent.
self-dose.
And the asthma patients would come to the nurse and say, "Oh, you got asthma. Doesn't look too bad. Why don't you go into the parlor?" And they would go in. They would build no RT. They would build their own little thing. You'd come in the room. They go, "I took a double shot of Prevental and one of the Atrovent. Could I have some prednisone?" And so there was no Pyxis. They would self-administer. Oh, Christ, Jaco. I thought their head was going to explode when they came in and saw that. They were like, "Oh, this cannot be happening." And we were like, "You mean because it's working so well?" This was working perfectly, and so they shut that shit down in a heartbeat. But we had it for years, and it really, really worked well. But it does show that this recliner chair thing is very popular among patients and things like that. Comment.
No, I was just gonna just echo what you said. Sorry. I work a lot of overnights, and I know David does too, and we come into a very full waiting room, and decreased nursing staff and parts of the ED are no longer being filled, and those beds that are filled are waiting for CAT scans or waiting for admissions, et cetera. And I think a big part of this is seeing the MD who's overnight. I often will see patients in triage and do the same thing. We have 2 triage rooms up there. Pull them in if they need a belly exam or something like that. Do it in there, talk to them and say, and it's just about kind of like the show of medicine. Hey, I saw it's a really nice waiting room. I'm going to pull you out and get things started for you. People love it. And I am going to have you come back and sit in the waiting room. I mean, a girl who's coming in for really out a DVT does not need a bed. A kid with sore throat, things like that doesn't need a bed. And so a lot of times those things can get started. You can talk to them. And while your ED is full and your colleagues are waiting to sign out and waiting for other things, you can still follow those people in triage. I have multiple times admitted people from triage that internists are like, where are you? Like, oh,
Yeah.
I'm waiting.
Yeah.
Right. Welcome to my world.
Thing. And
Yeah.
you still have privacy, and you can clear out a waiting room by doing that, especially at night when people have been sitting
Yeah.
there 6 to 8 hours for a very low.
There's another thing about working nights, which is at nights, and I'm getting old, and they hurt. I used to think nothing of doing 10, 11 of them in a row, and I can't do that anymore. But one of the things that's very different about the night shift is the ER doc and the nursing and the advanced practice providers are all aligned. If we
It's
can
because
just
there's no
bust
administrators. The
if we-
administrators are home sleeping.
Right, and
So you
if we
actually have to
can
do your
bust a
job.
move and see these people, we'll actually have an hour and a half at the end of our shift to drink coffee and look at our emails and gossip. Whereas the day shifts know that the ED is getting busier and busier and busier, and they're falling further and further behind. So in many ERs, there is this global sigh. You can hear it if you're outside the building. You'll hear it at around 2:30 or 3, where the whole place just goes, "Fuck it, I give up." And they just let them back up, and they just go, "We're never going to catch up." And so you get into this mix of you trying to work hard or other people I remember once I was working really hard and the senior resident was like, "Billy, what the hell? You're killing yourself. What are you doing?" Well, I'm like, "There's like 80 in the rack," and I remember she looked at me. She goes, "We haven't been caught up since 1933." What makes you think we're going to catch up today? But at nights there is a different attitude that if we bust a move, if we haul ass, if we, and it's one of the reasons why nights are always, and again, there are fewer administrators. It makes the work environment a little more pleasant all round. What else do you got?
Scribes.
Scribers. How many are using Scribes?
How many of you have scribes?
It's not fair. I have residents.
So
They
one of
sort
these,
are
yeah,
scribes.
one of these says Scribes for the slow docs. Don't punish the fast docs by only giving Scribes to the slow docs. But I'll tell you. So let me tell you about your own expense. We had a resident who hired his own scribe, which proved to be an interesting conundrum.
That's an interesting. Really?
Yeah,
You had a resident?
it didn't fly with our administration, but it was an interesting concept. And the reality is, if you are willing to pay for your own scribe, you're going to make the money back in spades. There are actually some papers that look at their value. Scribes basically cost you anywhere between, well, it's usually about $20 an hour.
Yeah,
they'll
but if
cost
you're a
you.
resident, you're salaried. You're just losing
Well, he
money.
also was moonlighting, and
Okay.
so that person went with him to his moonlighting job, and he graduated with a very expensive car, so he was doing well. Thank you very much. It wasn't from his county salary that expensive car came from at all, but the scribe thing is, it turns out that your billing goes up, your efficiency goes up, and what is probably more important is your quality of your job and your quality of life goes up. You now suddenly aren't doing all that crazy stuff there. Now you have to be careful. So there are only certain things. Scribes cannot enter orders at all. You'll get in trouble. Cannot do it. So you got to be careful with certain parts of it.
Can't chart the physical
Can't
exam.
chart the physical exam. You got to
they
do
can
that.
chart it, but you have to do it.
Right. So yeah, chart it. But the thing is that it's really honestly, depending on your group, they're going to have to work out numbers. But a lot of groups have just decided that for longevity and often financially, it's more beneficial to have scribes.
Can do the review of systems. Yeah. So one of the things now that I just caution, and you guys probably all know this, but I think it's just worth to phrase it up in a way that kind of sits home. In the old days, in the Wayback Machine, so 15 years ago, the line, particularly if you were talking to lawyers and talking about med-mal, was if you didn't chart it, you didn't do it. And that was sort of the driver of charting. Now the problem is you charted it, but did you do it? So people are importing these macros that have all this crap in them that they didn't do. And what we're seeing now in the med-mal world is when those charts go when there's a bad outcome and there's med-mal, the lawyers pivot very quickly to a detailed analysis of the macro. And an interview with the patient says, here, sir, that your rectal exam was guaiac negative. Did the doctor put a finger in your anus? No. Trust me, I would have remembered that. They never did a rectal exam. So what's going to happen next is the lawyer's going to pivot quickly to fraudulent charting and fraudulent billing
so different.
In anticipation that, no, we'll talk about the med-mal in a moment. Mm-hmm. First, let's talk about the fraud that's been
jail.
committed in billing. Yeah. And so you got to be really careful with bringing these in, because then what happens is your group, which was going to defend you to the death, we're all grabbing our swords and we're going there with burning flames and we're going to defend you. Now they're like, fuck it, throw them under the bus. Because the last thing we need is a rack audit here and some other shit going on that's going to affect us all.
One of the ways we got around that at our place was all of us have our notes pre-written like you're talking about. But I talk to the scribe as I do my physical exam, and I just tell them, this is an ankle, so take H, E, and T completely out. I didn't do any of it. And when I examine the ankle, I tell them, put in this or that, and then you can put in 3 asterisks so I can't close the chart, and then I get to review it. Same with review of systems. I didn't ask about their smoking history when they turned their ankles, so take that out. And my scribe is sitting right there typing and taking stuff out, so when it's done, it isn't accurate chart. I agree. When you have a complete physical exam for a turned ankle, they're going to say, why did you do?
Especially the pelvic.
Well, and it's really not a scribe issue per se, it's an EMR issue. Yeah. So whether you have a scribe doing it or whether you're creating your own notes, a lot of people are creating their own notes largely from macros. And as Billy's saying, you can get into a lot of contradictory information. You get the sex wrong, you get everything wrong, and it just makes for a chart that reads well and reflects poorly what actually happened.
Well, the other problem is macro plagiarism. We see a lot of macro plagiarism from the consultants. So the consultants go back and look at the clinic note from 3 days ago or 5 days ago or 5 months ago, and they import the history. They didn't talk to the patient at all. The history from that last person, assuming they got it all right, and then you're looking at this consult note that says your patient's on meds that they're not on, that they're still waiting for their scheduling for their cholecystectomy. Meanwhile, they've got the thing out. It's from 5 months ago, and so just like macro importing for you charted it, but you didn't do it. There's a lot of consult notes that are having macro plagiarism where what's been entered into the record for today has nothing to do with today. Says they're a hardcore alcoholic. Trust me, the patients get pissed off when they've been at AA for 9 months. And they're doing the best they've ever done with their cessation, and your record says they're a drunk. They don't. When that goes to court, they're pissed off. Trust me.
But we talked about this with one of the articles yesterday, the 4,000 clicks per 10-hour shift article, and that translated to the physician doing data entry 44% of his or her time. And I think if that's what your reality is, that you're doing all your own entry, it's consuming a huge amount of not just your time, but your brain power. Like Billy said, that really eats at your quality of life. And we implemented a Scribe program within the last year, and I was the guy that rolled the computer in, and I tried to look at the patient and type at the same time.
Not good. Patients don't like it.
And now I get to sit down, I shake hands, I look the patient in the eye, the scribe's in the corner, and I get to conduct a history that I like and is reflected in the chart without my doing it.
All right. No, go ahead.
Go ahead.
So I'm just asking, when you have multiple physicians working at the same time, do you share a scribe, or are they physicians?
I got my scribe. Yeah. My scribe shows up, when I show up, and he or she leaves when I leave. And most of these, I live in Denver, there's, a young, educated population there. Most of these scribes are college, pre-med, pre-PA, NP type of students. They love being in the ED, and they're a smart, hardworking group.
Everything's great until the Scribe divorce occurs.
Yeah.
The Scribe divorce is already a defined entity. It's happening. Trust me.
Or they graduate and they go to medical school. It's like, no, you can't.
Right,
go.
and so now we're in emergency medicine residencies. We're seeing a lot of people who have scribed
four
before,
of our new interns
who are
were
applicants
scribes.
to your residency, and it's very interesting because I feel like they actually know what they're getting into a little more than sometimes a person who's done 2 big academic rotations. I rotated at the Beth Israel and I rotated at Stanford. I'm like, you have no idea what you're getting into. So you don't know what the job is. Is that what you're telling me? Whereas the scribe, it's like, yeah, I know what nights feel like. I know what this is like.
Is anybody aware of someone who's had a scribe program and failed on it? I think it's just a slam dunk.
So I know that there are places that did it and decided that the cost analysis wasn't good, primarily driven out of the C-suite. It was sort of a symbolic slap to the ER docs. We're not doing this for you. We don't have scribes for cardiology. We don't have scribes for these people. So I've seen the C-suite slap saying we're not paying for this as cuts came down. But I don't know of any ER docs who don't like it. And regularly when Rick is here doing this conversation, he talks about in places where they've lost their Scribe program because of financial pressures, many of the docs have gone on to independently hire them.
Right.
If you have 1099 income, that's beautiful. Independently hiring the Scribe helps your tax protocol. They're part of your business expenses.
And actually,
Until they're part of your divorce.
There's a very busy ER in LA County that actually has scribes for every level provider, including all the advanced practice providers have their own scribes.
All right,
So-
here's one I want that someone puts in, which I think is also really variable. How much do you let your techs do?
Ooh, techs are awesome.
So, how many of you have techs, ER techs? And how many of your techs are able to do things like EKGs? Great. So, a lot of places don't let them. Our hospital won't let them.
Nope.
How many of them can do complete wound prep and things like that before you get? That's beautiful. How many of them? So most of you guys have a very liberated tech protocol.
They can't inject wounds.
Our
No, you
techs,
set up.
our techs couldn't do all kinds of stuff.
They can irrigate.
And I actually had the conversation with our nursing director. This is also about 14 years ago. You can imagine how this conversation might have gone, where she said at the end, towards the end of the conversation, "Over my dead body, will we have techs that can do that stuff because those are nursing. tasks." So then, what happened was the Navy from here, from San Diego, came up and said, "We really want a trauma center where some people are shot and stabbed so that we can have a Navy trauma training program." And we were like, yeah. You'll get 2 free faculty. Yeah. You'll get free anesthesiologists, 2 trauma nurses. Yeah. We were like, yeah, sounds really good. And you'll get a ton of corpsmen. But our corpsmen, we want them to be able to help putting in shoulders, doing suture, and so now the nurse administrator was faced with the anti-patriotic choice of shutting down a $3 million gift to the hospital that was the Navy per year, which was the Navy Trauma Training Program, or acknowledging this new position which totally defeated the obstruction, which was Navy corpsmen. And so finally, the walls were broken down. So I recommend you, if you're having troubles liberating your text, which most of you don't seem to be doing, do the corpsman end run.
We don't have them. Our nurses kiboshed it completely.
The corpsman, have anyone worked with corpsmen? Oh man, it's the greatest. They will do anything for you.
It's a union thing? Yeah. All right, point of care testing. Somebody loves point of care testing in this stack of things. How many of you guys use point of care testing?
How many have an iStat?
We use for sure, most of us do, the pregnancy test, which is wonderful, and a sugar. The question is, do you go beyond that? Do you do troponins? Do you do an iStat?
How many have tropes? How many have tropes?
We have access.
And the first trope I don't think is important, right? The first trope, you got a chest x-ray and a few other things. It's the second trope where the turnaround time hurts. And so I think that the point of care testing becomes useful for the second trope if you'd like to be able to make decisions sooner on these patients. Because one of the advantages, although there are lots of disadvantages to the ultrasensitive troponins, one of the advantages of the troponins is because there are a little bit tighter confidence intervals around the values in terms of accuracy of a troponin. There's still some variation, but it's generally less than 20% or so. They're tighter than we were with CKMB. And that tightness is actually really important if you want to talk about what the delta is to your next trope. And so delta 3 hours has been pretty well studied. There are a bunch of places that have looked at delta 3, and some places are pushing to delta 2. I personally am doing delta 2 tropes now with the high sensitivity trope. And that's why, while the trope hasn't solved all our problems and you have to think about it when you're getting high sensitivity tropes, we haven't thrown them out because I like the delta 2. Give me that delta 2 trope, and I'll start making some decisions in a time frame which is compatible with an emergency medicine workflow. And so that's kind of nice. And that for that second troponin, it would be nice if I had the fastest turnaround possible, because that's going to be the last data point I'm waiting on for a decision with that patient.
I think when you're looking at point of care testing, as Billy's pointing out, the key has to be whether that's improving your efficiency and throughput time.
Exactly.
So getting that troponin up front when you're doing other workup is rarely going to be helpful. We have point of care in our radiology suite where the radiology techs, the CT tech, will run a point of care troponin if we're doing IV contrast. So they're
Troponin or creatinine?
They're not creatinine.
Thank God.
So
I was like, you need. Please don't tell me we need troponins
So they're
to do
not
studies.
waiting for the BMP to come back an hour, which is our usual lab turnaround time, to call the patient for the CT scan. So
see, that's an evolved, independent, self-reliant radiology group that realizes that they have a service function for the emergency department who obtains their own creatinines to get the study done for you. At our hospital, we have something like that. No, we have nothing like that. We tell them the creatinine, and they go, "That's not good enough. What's the GFR?" And you're like, "Let's step outside. Can we step outside? Because I want to give you my GFR." But anyway, so yeah, some places are less cooperative than that. And I love it when they want the creatinine on some 20-year-old who's, completely healthy on no medicines, who's there for, a head bonk. You're right. I think he got his head injured at the bar because his creatinine was 3. I don't think so. You're killing me.
What else you got?
They have, this was an interesting one. I don't know if I've heard this one. They have an unresolved issues track on computer for admissions. So they actually specifically say, I got this patient, we're kind of done, but we've identified there's like a stream we can't jump over, there's a hurdle, there's a dead policeman in the way, what is it? And it has apps to call back patients for positive cultures, radiology discrepancies. Thank God, because I already mentioned how this is ruining my morning sometimes. And it frees up the MD and EDs and the advanced practice providers to see patients and not spend time on the phone. So I think that sounds very evolved. Anyone have something like this, a track that does this and takes care of it?
We have an RN program that will respond to labs. So blood culture, urine cultures, all that kind of stuff.
Beautiful.
We don't do any of our labs.
And do they phone these people? And
We have a protocol set up, and if there's some question, they'll call whoever's in the ER and can be reached easily, one of the providers.
Yep.
But that happens probably once or twice a week.
Beautiful.
We take care of all of our labs.
How about radiology discrepancies?
Currently, we're still responsible for our own radiology.
Anyone else? Different comments, different methods, different solutions? Yeah.
We have a lead physician that works 10 a.m. to 10 p.m.
A lead clinician, you're calling it?
It's actually a lead physician, and he or she takes phone calls from 10 a.m. to 10 p.m. Those phone calls include transfer units, and they start their morning off doing labs, red, all that, whatever they need to do, so they clear our results.
So we had a similar thing. This is old county history. Diane knows a little bit about this.
Yeah.
We had a similar thing. Back before there were rules for trading for residents and duty hours and stuff, the resident schedule will come out, and we wanted to know in our critical area where you're doing resuscitations and intubations and stuff all day long, it would be a disaster if the the senior residents had all traded their shifts away with interns and 2s. You'd come into that area and be like, Jesus Christ, I'm working with 3 interns in a second year in research. You're like, I won't be able to go to the bathroom. I can't leave. So we had to know. So we wanted to know so that they couldn't trade out and leave no seniors in the area. So we started putting an asterisk by the seniors' names so that they would know when they were trading that they had to make sure this is a shift you can't trade with a junior. You can only trade it with another senior. And then we decided to have a lead physician, the senior in charge, who would coordinate who was going to lunch, take the transfer calls, things like that. And so that became a 2 asterisk position. And that became known throughout the hospital as the 2-star. Now, what was the unintended consequence of having the 2-star? Well, these militaristic specialties really loved this idea. They thought it really sounded like a position of authority. So ortho and surgery really responded in a different way. They're like, well, let me get the 2-star. And it was, even though it had nothing to do with any real authority or anything, but the illusion of authority was very effective when dealing with surgical consults. So I recommend that you give your lead physician some assignment. Maybe they deserve more than 2 stars. Maybe they should be the 3-star. But you'll find that the aura of authority will be powerful.
The lab radiology callback, I think, also brings up the topic of patient callback in general. There have been a couple studies looking at improved patient satisfaction, and as many of us are under the press gainy gun, anything we can do that's actually not impacting how we actually do it sometimes is what we grab for. So we've done patient callback, but it's essentially the provider, either the physician or PA in my department, who actually does the calling. We have
So next day or when?
Anytime, we try to do it anytime within the first 4 days or so, and you can't do it past a week in order to get credit. So we actually do track this. But I'm curious, first of all, how many are doing their own callbacks, if you're doing callbacks? And I would love also to hear if anybody's gotten their nurses involved to do nurse callbacks.
So I know a few docs who do this who say patients love it and everything's great. I guess in my hospital, part of the thing is I only speak 2 languages reasonably, and I would need to speak 7. My Armenian, my Vietnamese, my Mandarin, my Cantonese, not so hot. So I can't call those people back. So how do you deal with that?
You can if you're very inspired. First of all, it's a hugely selected patient population because you know who liked you, you know who it went well, and so you're not calling back the person that you had some issues with. You're calling back to people. It's like, thanks, doc, that was great, and then you're calling back 2 days later, and you're still great. But if you were very inspired, and I think I've done this a couple times, you can go through the language line and have them call. But that really does turn it into more of a hassle.
It might just remind them how terrible the conversation was the first time. Anyway.
So,
anyway, others doing it.
We have a follow-up.
Got it.
All discharge papers is the bottom of that is we have a available nurse, their numbers here. Often if there's anything outstanding, like Lyme type or whatever, another significant factor to be able to
A New Yorker here in San Diego.
So
the
is
Lyme
that-
titers, huh?
Is that everyone being discharged gets a call back by the nurse?
They get the number, I can often say, give an outstanding test in your primary care system and stuff, but there's a urine culture pending. I want to know, I'm not going to be looking back at cultures, I put them on the right antibiotic, they'll never see the PCT in this kind of fashion. Any positive culture, any significant results, and how it's flagged, all of the
So do you have to flag a chart?
the micro, or a certain positive line culture, urine culture.
So that's more.
I can see that call now, ma'am.
The lab radiology.
Their specific job doing that. Now you also just quickly say you have an outstanding test. Please call a follow-up.
Does
Hi,
that-
Mrs. Jones. All your tests are back. It's true. You have fibromyalgia.
Does anybody work in an ED where actually every discharged patient's getting a call by somebody? We have a couple.
Really?
How are you doing that?
Every day. Every day.
Wow.
Surprised how many wrong numbers or
Yeah.
the contact.
Yeah, some of those are intentional.
So I do know of a hospital that was having trouble with their Press-Ganey scores, and because the CEO often
had
is,
them.
Yeah, yeah. Well, the
That's the
CEO
first
is
problem.
often paid based on how well your Press-Ganey scores, how good they are. One of the things they did in their ER to improve things, and this is how it's all in the spin. So they all got calls. Every patient who was seen got a call. First of all, they got a little card as they left saying, "Thank you for letting us take care of you at X General Hospital." Then the next day, they got a call from someone who said, "Hi, this is Nurse so-and-so from X General Hospital. We would like to just touch base with you about your excellent care that you received here."
Yeah.
And literally the patients would say, "Yes, I did." Chick, done. So it primed the pump, and it was another way to sort of, it's all in the spin.
Administration wanted the docs to actually do the discharging, and then at that point to ask them to give us 5 please for our president.
Wow.
Oh, now see, that's gaming the system a little too far. Hi, I'd like to discharge you. And see this, so we do this with the evaluations for this course. You'll notice that they're already circled. No, I'm just kidding.
Just check here.
That's the car
That's a little
dealer
bit of
thing.
cheating.
Is there
We'll
anything?
let you go home.
Is there anything I can do to make sure you give me a 5 when I call you back? So
my prescription
were you
pad.
were you actually comfortable doing that? Was that?
I didn't do it.
Yeah.
Yeah.
Nurses do it, but that's what they wanted us to do.
Yeah.
I'm not doing this.
How much is prostitute are you? Just kidding. Just kidding.
Hand
Yes.
over here.
Loud, loud.
Loud, loud.
Our emergency room is so busy that anything that can be done to both the nurses and the docs and the advanced practice, everybody, too busy. So we have this admissions facilitation team. So once people are admitted, advanced practice providers take care of them. This also falls underneath us. 'Cause that's where I work. Any cultures that get done automatically get put onto this track. And we follow it. The emergency room doctors, nurses, whoever, nothing to do with it. Once the patients are admitted, even though they're still in the emergency room, they have nothing more to do with them. They can keep seeing other people. And it has helped a lot.
Cool. Cool. So there's some other comments, and I haven't seen, I don't know, maybe it's on one of yours or yours that I haven't seen that come up all the time. So one of the new sort of abscesses that needs to be drained is, tell us how you're managing your psych patients who are on a hold and can't be placed. So
Yeah, there's a
if
couple in here
someone could
about
tell me
having a
what
psych-
your
what are
success
you
stories
doing?
are, feel free. Any success stories out there?
Oh, there's a really lot of sad faces out there.
Program called JACK, and I don't know what the acronym stands for, but in our central psych hospital, we have the social workers, the QMHPs that are available 24/7.
They Skype in.
Yeah, we're in a facility that's about an hour away from
All my patients would be like, I'm hearing voices coming out of the computer already.
the computer, and then that QHP can Skype with the patient, and then I also talk to the patient, and then I talk to the QHP in real time, and we say, I think this person does need permission, and then they take care of everything. So they've got access to a bed, they've got the ear of the psychiatrist, so they're able to turn to the psychiatrist and say, I've got a patient.
That's a nice system.
This. And of course, the psychiatrist listens to them way more than they listen to an ER doc. And then they facilitate the whole process.
Wow, that's interesting.
That's
interesting. So Skype and Psych. I like it.
Skype
we
and
have to
Psych.
come up with something. You need to write up.
That's actually
because I have
pretty cool.
that actually is a very innovative program.
heard
I've
of
not
that.
heard of it.
Yeah.
I'm telling you, for an academic journal, you need to write up Skype and Psych. Yeah, it's
I've
cool.
seen one article where it's essentially telepsychiatry, telebehavioral health has been instituted, but it still begs the disposition if they need to be admitted question in my.
Our problem is, I can say this person is suicidal, and they'll say, well, we have some beds on hold, they might have someone in this hospital, but this is someone who's at that
Wow.
hospital. It says, bed 3 is for the person from Princeton, they're on their way, and they facilitate.
Yeah. I'll tell you about one successful thing we did. So we have a separate psych ED, but many of our psych patients, as you, again, might intuit in a county sort of homeless population, they got medical problems. So they're not quite medically cleared. So we actually developed a specific med psych place where patients both on holds and not on holds can get ongoing medical care, but there's a mix of regular nurses and psychiatric nurses, so if they need antibiotics or some simple, they can't go if they're there if they need ICU care, but a dedicated, I don't know what it is, 10, 12 bed med psych area helped decompress our ED a little bit. So that was one thing that we did. It's sort of like a med psych OBS. They get a couple doses of antibiotics, things are looking better, then they're cleared, they go to the psych ED.
It's tough, I'll tell you. I think that's really hard. We ended up having to, I know you did it county too, for our peds. What is with all the crazy kids?
Holy cow.
What is going on out there?
Well, let me say one thing about crazy kids, though. You do not want to be the last doctor to talk to a kid who the mom is begging for help with, and that kid goes and completes a suicide, because there will be hell to pay. When you don't listen to that mom and that kid's screaming for help and someone says, well, I think we could manage him at home and we've contracted with Joey and Joey seems reliable, and the mom's like, please don't let him home with me. And and someone does, if you're the last doctor and that ends in a completed suicide, there will
the
be
other
hell
thing
to pay.
that I think we've run into, we don't have the resources for them to go basically anywhere. We hold them for days and days at a
5
time.
days, 6 days.
Children and adults, but it's just heartbreaking. These kids are in rooms. And one of the things that if you end up in that situation, we actually discovered this the hard way, is that you better have a room that they can't hurt themselves in. So just holding them in one of your rooms with the otoscope on the wall and the computer cord on the wall, and please don't. That's something they can use to hurt themselves. So we inadvertently ended up with a room like that when a patient went ballistic in the room and literally ripped everything off the walls and threw them through the window.
The last thing
Every
you want to
single
be-
thing, the computer screen, the monitor, the otoscope, everything got ripped off the walls. That's now our holding room. It got stripped to the walls by this one wacko guy, and it was a dangerous situation all the way around. So be careful on where you put them in your place.
Make sure that when you leave them hanging, you don't actually leave them hanging.
We actually have something we call the garage door where all of our.
The garage door.
in one section of
Actually, that's really smart.
And we can pull it down and lock it so that the room is still available for non-psych patients without having to.
So if you're designing a new ER, this is something that a lot of people are building into their ears. It's called a garage door, where it actually is something you can pull down and lock at the bottom, and it's usually metal. It's not usually see-through. It's usually metal, where you can take someone who's violent and actually have them stay behind this where they can hurt no one, and there's nothing inside that can really hurt themselves with either. But with the garage door up, it's a patient care room for patients that if you need to have them sit in there. And a lot of ERs are putting these garage. We don't have those. I wish we did, because this guy
Does it
literally
have a Haldol shower?
Yeah.
I need a garage with a Haldol mister.
Billy brought up the point of this contract for safety, and just since that came up, I had to mention it because it's really one of my pet peeves with mental health. That if you're looking at the history of that, there is no validation. That is not a predictive element in the behavioral health assessment. What is predictive is past history and behavior and known psychiatric problems and support system and drug use and access to weapons and those sorts of things. But to pull from the patient he consented to be safe type of admission.
Or contracted.
He contracted for safety is really just crap. So if you're hanging your discharge on, he contracted, like we can believe what they just told the behavioral health person, that is a very shaky platform to be basing your mental health evaluation
By the
on.
way, we've also got literature in the database here that asks who's better at predicting whether they're actually going to go to a completed suicide, is the ER doc or the psychiatrist. And so it's very clear that this is a completely inexact science and that we're just about as good at it as them. So if there's a discrepancy in between your opinion and their opinion, don't assume that because they're a psychiatrist, they're right. You may well be right. And so listen to that inner voice. If you're really worried about someone, this prediction thing is a very inexact science, and we're just about as good at it as they are. And we don't have great kappas when you compare the psychiatrists to the ER docs. We don't have tremendous kappas about it, but neither is superior to the other in terms of the actual prediction of who's at highest risk. So how many of you are aware of the Washington state law? So state law, once
Love
a
this.
state...
So this came up the other day as far as damned if you do and damned if you don't. Sometimes you're stuck in a position where you're going to break somebody's rule because both of them are contradictory. Go ahead and tell them what that is. But it's
so in Washington state, they looked at these people who were confined in ERs on involuntary holds for 4 to 5 days with no psychiatric care. So 4 or 5 of those crazy people, when they were sufficiently hospitalized and rational, got together and brought suit against the state for illegal confinement, and because they argued that psychiatric confinement should come with psychiatric treatment, and they were receiving none. So they basically was sort of, I don't think it was exactly a writ of habeas corpus kind of thing, but that was part of it, and they won. And the governor said, you can't do it anymore. And everyone said, yeah, well, great. What are we going to do now? We got nowhere to put them. So I appreciate that you don't think we can do it anymore and what the legal standard, what the statute says, but we still got nowhere to put them.
crazy.
So they're building new psych facilities and trying to expand the ability of the psychiatric community to manage these patients, et cetera, and get them out of the ER. And I think they set some rules, some hour length. I don't know if you know it.
Right.
And many, many states started having interest in this. So I would expect
Coming soon to
that
a
example
near you.
that may be coming soon to a state near you.
Yeah, we have an OBS unit, and psych is specifically excluded from there. So we're left kind of hanging what to do with these people awaiting disposition, and most of us are not terribly keen on acute medical intervention. Am I writing for the Zyprexa? It's really not part of what I trained to do.
Wacky.
Any other psych comments about how many of you are, let's just, so that we can share each other's miseries to the extent that we can, how many of you are having problems with getting psych people out of your departments?
Oh my God!
So-
It's everybody. It's the current. It's our big
All right,
crisis now.
let's do one more fun
Actually,
thing. The longest number of days.
Oh jeez.
All right, I'll
We have
start. I'll
5.
start the bidding with 5 days.
I have
Anyone
5.
got longer than 5 days? How
Oh
many?
jeez.
8?
14.
14. Who could be 14?
Going once, going twice.
Boom! 14
winner.
days it is. You can tell your group
Unbelievable.
you were the winner.
They can change their address at that point to your hospital. Just put in a change of address form. Oh my word.
Wow, think of that sign out.
Yeah. Yeah.
Yeah.
No kidding. No kidding. How many of you have anybody doing anything about the upstairs, getting them upstairs problem? There's a couple of suggestions that came across.
So access block and how do you
Access
fix
block
it?
or whatever you want to call it. So how many of you? So what has worked at your places? Please have a hand go up that something has worked. Yes.
Well, like I was mentioning, we have advanced practice providers that are hired specifically for admitted patients. They do the admission orders, so they don't have to wait for the interns to come down and do the orders or the residents. And we don't have to wait for the hospitalists to be free enough.
What about a bed
So
upstairs?
they work for the hospitalists, these advanced practice? They work for the ED, but they work to get people out. All right.
We stay in the emergency department, although we're now staffing the ops unit also. Because it's like a whole admission
So you guys write the holding orders. Don't wait for the intern to come
I might
down.
rather
You
be in
facilitate
triage.
getting them moved. Yeah.
And some of that is, we are the ones that the interval people will call. We're the
Yeah.
ones that they
I'd definitely rather be in triage.
full admission.
Yeah.
Well, you kind of learn the rules after
Yep.
a while.
Yep, you learn
So
the
what
game.
you've done is you've put somebody as an interface between your ED and getting them upstairs.
Are you writing
How about
admit-
the upstairs? And have you addressed the if they're full or the nurses upstairs are giving some sort of?
Care of them in emergency.
So
Okay.
ER doctor.
are you writing admit orders?
Yes.
Yeah.
Who's got someone?
Hospitalist service, but in the meantime, we take care of the septic patient, the
Yeah.
AFib, whatever, that are sitting in the ER, because ER doctors have new ones coming in all the time.
Right.
They don't take that.
And are you?
Who's had a policy come down from the C-suite or from nursing upstairs where it has helped you? Anyone? Yes. Shout.
Loud.
Under a stranglehold by the nursing union,
Yep.
staffing needs.
Al-Qaeda.
We were generally holding because of staffing.
Yep.
And it was sort of, they seized the right opportunity when the hospital came to our department and said, your whole times, you're not good here, you're not good there. We said, because you don't have staff upstairs.
Yeah.
It was a perfect storm, perfect timing, and somehow they got to the union and were able to make some changes, and staffing has improved.
Well, and a lot of things, just so you know, there's now a national push, a federal level push for this nursing ratio thing to become a federal standard. So if it is not in your state, it is highly likely that some version of this will end up passed at a federal level, where minimal nursing ratios are going to be sort of mandated. And I think it's imminent. I don't know. Billy's a little
Yeah.
more finger on the pulse of this,
Yeah.
but that's helpful. The other thing though is to have a CEO who really gets it. So one of the things that we in LA County have a thing called the NEDOC score, where there's a score. It's kind of a weird score, to be honest, but there's a score that will say, you're sort of in the yellow zone, the red zone, or the black zone, where it is so completely backed up that something has to give in the system, or someone's going to die. Someone's going to get hurt. And what should happen as part of that, which hasn't quite happened at our joint, but what should really be happening is not just who's where, who can get discharged, who can get downgraded, who can get moved upstairs, not you, up there. But the other thing is to do things like cancel elective surgery. If you know what this is, none of this is rocket science. The flow
And
of the
elective
ER.
admits.
All the elective stuff's got to go. If you have internally within your system a problem, that's where the bottleneck is. The elective stuff stays out. It's elective. That's the word elective. That's exactly the functional part. And CEOs are reluctant to do that because that's where a lot of money comes from.
Right. Those are all the wallet biopsy. Every elective admission has had
Will pay.
had a selective wallet, a successful wallet biopsy first. So when you say you got to cancel the elective admits, they go whoa, 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 whoa. The next
that
thing
gets
that
people
you
excited. Yeah.
that you can do is go to hallway beds, and we're finally at county.
Unbelievable.
We're going to
I'm shocked.
We're Vicellifying. We're going to hallway beds.
Your
starting
hallway
next
is better
week.
than
Yeah.
my hallway.
In the ward.
Yeah,
On
on
the
the
ward.
wards.
Question in the back.
Yeah, I don't work at a big hospital, I work at a little one, and the mothership, they actually did a study and found that the biggest backlog was in housekeeping.
Yep. So we went to yep.
And just getting those beds cleaned and turned over has made a huge difference.
So
Absolutely.
Yep. So we had the same problem. Sometimes it would take 4 hours. So we had to develop. I mean, this is the crazy shit you get to. We developed a dirty bed policy, which is the nurse says the bed's dirty. We're like, fine, patient's coming up anyway. They'll sit outside the room and now the nurse is like, what the? And so now suddenly the bed is
It's their problem,
The
not
room is
ours.
cleaned in 30 minutes.
That's
rather
where,
than
so
2
that's where
hours.
this hallway bed thing is kind of cool. So Peter Vicellio, who's part of the faculty, who wrote some of the big papers looking at hallway people, why your hallway is any different from my hallway should make no difference. And they shove people upstairs. It's like, fine. It's not the critical people, but it's the ward admits, and they can sit in the hallway. And actually, to be honest, the patients like those hallways better. Although I think our hallways in the ER are more entertaining than the
More
hallways up there.
entertaining and more infectious.
Yes.
Whatever.
But they like it better,
we have-
and the nurses hate it. And magically, beds that weren't available were suddenly available. People don't wait up there the same amount of time as they wait downstairs because it's in their face. They don't like it. The nurses don't like it. And the things, that all happens. The bed gets taken care of. It's remarkable.
We'll start here, and then we'll go there next. Go ahead, loud again.
A thing that's helped us is that for inefficient docs in the ED now, because when everything's back, when everything ordered, when it's all back, the computer flashes the color and lets people know that that's helped get people upstairs.
Just order blood cultures on everybody. It'll never bother you.
How about your comment?
In our ED, we implemented the same throughput system that Mayor's talking about. But housekeeping in the ED was also an issue because they had a standard for cleaning every room, assuming the patient's been in the bed for a number of hours, full wipe down, etc.
Yeah.
As soon as the patient just comes in, sits on a chair, gets an evaluation, and leaves that room, the housekeeping duty for that room is now minimal. Okay, nobody-
Yeah. I've always said,
ED that turns over is the housekeeping people on board, not doing full cleans on every single day.
yeah, that's it. There are issues there, and I've always said I learned more about being an ER doc waiting tables than I did in medical school. So one of the things you learn in when you're waiting tables is you tip bus. The only way to turn your tables and seat new people is to have, I mean, you want that table bussed. The second the bus boy hears that scraping of a chair moving back, boom, that thing should be clean because you want to seat more people.
I wish I could do his sound effects.
And the other thing is that waiting tables also teaches you the difference between seeing more patients and going for check total. So when the restaurant's slow, it's all about check total. You need to sell wine. You need to sell appetizers. The ER slow. Maybe I'll do some procedural sedation. I'm just kidding. I'm just kidding. But when you're in the private world, there is some check total calculations going on out there. And so it's not completely outlandish to talk about it because there is check total stuff going on. But bus is really important, and that's why these dirty bed policies, both in the ED and upstairs, become relevant. If you allow that to become an impediment, it can be an impediment.
I think if your administration is still talking about the problem of ED overcrowding, then the
You need to fire
perspective
somebody.
is wrong. So it's a whole hospital flow policy. One of the things we looked at was discharges by the internal medicine service, that oftentimes they would round on their discharge patients as their last patient. Well, they're the stable ones, they're going to be fine, they can wait. And discharges would happen at 4 or 5 in the afternoon. And by turning their rounding schedule around to make them round on the people who are likely to be discharged, and then to get them out the door and not wait, well, my son will be off work at 5 and he can come get me at 7, that doesn't work either. And it's that kind of flow that backs us up in the ED.
So what Dave is talking about is this thing that you don't often hear the words, but if you talk to the mathematicians, it's called stochastic analysis, which is where are the bottle pints and what are the theories of queuing. So if you want to read Scientific America, as a journal on this, it'll tell you why a hill causes a traffic jam on the 5 North. And they'll go into the whole stochastic analysis. Why a bar mitzvah let down on one of the side streets could screw up this highway. But when they do the stochastic analysis for emergency departments, and it's been done over and over and over again, and the result is always the same thing, the answer is, what's your total hospital capacity? And the answer is, you need, since they're not building new beds, you need to increase your hospital capacity. And the only way you do that is by decreasing length of stay. And even small decreases in length of stay positively affect total capacity of your hospital. So early discharge, when your ED is overcrowded, the first answer is early discharge. And by every hour earlier you discharge it, so let's say it's 4 hours early, that's a 1/6 of a day decrease in length of stay. So for every 6 times you do that, you created a new hospital bed for a whole day, even though your facility didn't change size. And so the stochastic analysis always points to this, which is why when I was the president of Cal ASAP, if anyone said the words ED overcrowding, I kicked them out of the meeting. It is not ED overcrowding. It is hospital overcrowding. The solution to this problem is not in the ED. But you always have to say to the C-suite, yes, we'll rack our brains on our turnaround times and our fast tracks and all the things that we can do to marginally fix small elements of it on our side. We will be compliant. We'll be team players. But, asshole, the problem's in your court. It's on the hospital side. It's about early discharge and increasing hospital capacity.
And people have done these computer modelings that, of course, the assumptions are key, but given the usual assumptions, building new ED beds versus building new upstairs bed or a couple ICU beds, those are the things that really impact ED length of stay.
Multiple studies have looked at, will building a bigger ED work? No. It's not ED volume. It's not ED size. All the things that work are about early discharge and decreasing length of stay.
I'm not sure if anyone's mentioned, but we have a bed placement nurse.
Who's on your team, not their team?
The whole team.
Okay.
We don't get her in our department till roughly 5 p.m. and she's there till 8. So she's traveling the hospital most of the day, doing those discharges, pushing.
And smoking out unoccupied beds.
She smokes them out because we had major issues with our coordinator calling for a bed. Oh, no.
Right.
We don't have a well, whatever the excuse was. So we have, honestly, I'm amazed at how it has.
It's a bed czar.
Yeah. A beds are.
Yeah, it's great. And they know they're coming. So it's like they just resign themselves to doing the right thing.
One experience with you. Don't go up there and do it yourself.
No. He ended up on the front page of the LA Times for doing this.
It
not
doesn't
kidding.
work. If you go up there and find empty beds that are staffed and point them out as the emergency physician, I could tell you it won't go well from personal experience.